Okay. Hey guys, thank you for having me. So it would be an interactive session. Hopefully you would enjoy it. So my objectives is just like to have some skills to approach hepatology cases, either outpatient, inpatient, especially in floor and ICU, and some tips and tricks in initial workup and management, and that would be like interactive. So I have first 4 short cases for our first take-home message. Who want to do the first case?
Okay, I'll read it.
Okay.
So a 22-year-old physical active male with not significant past medical history presenting to the clinic as a new patient visit for an annual exam. A symptomatic physical exam is normal except for subtle icterus sclerae. His comprehensive metabolic panel is remarkable for an ALT of 20, AST 25, total bilirubin of 2.3, and an alkaline phosphatase of 76.
So
What's
what's the abnormality here?
So I noticed that total bilirubin is higher than normal. The LFTs the rest of the LFTs are okay. I believe the AST and ALT is usually 30 to 40 on average, the upper limit of normal. So the total bilirubin is the only thing sticking out, and the icterus sclerae on the physical exam.
The subtle, yeah. So what do you want to do next?
So like something like that you could do is like you could set for a hepatitis panel, but this could be possibly that he could be having some Gilbert syndrome, which there is an increase in the total bilirubin, but otherwise it's a very benign condition. Yeah, aside
so
from
like full
I will also
LFTs.
ask, sorry?
We'll do then full LFTs to see if it's based on the direct or indirect, right?
Oh, that's true. Yeah, we have to know if it's direct or indirect. Yeah, it's true.
Okay, so this is the rest of his LFTs with normal direct bilirubin. So it's mostly indirect. Is there anything else that you want to do before saying that it's Gilbert?
Yeah, like you could ask some few questions like social life, like alcohol, also like any family history of liver disease, or like any other ones with the same symptoms, usually any other toxins.
So he mentioned that he would have his family member would notice that he had like subtle yellowish in his eyes whenever he has like to like excessive exercise or fasting. Otherwise he's usually healthy, minimal alcohol consumption, no family history of liver disease or hemolysis, hemolytic disorders.
Can do is repeat a non-fasting. Sometimes it will just resolve.
Yeah, but just like I want like just to make sure that this is only like indirect and it's like Gilbert. I just like want to do CBC just to make sure that he doesn't have like hemolysis, underlying hemolysis disorder. So his hemoglobin is normal, DH normal, haptoglobin was normal, and reticulocyte in the normal range. So it's like isolated elevation in his indirect bilirubin in a healthy patient after exercising. So as you mentioned, it's like most likely Gilbert syndrome, which is relative deficiency in the enzyme that usually convert the unconjugated bilirubin into conjugated or direct bilirubin. Okay, next case. Who want to do it? Shireen, you want to do it?
Sure, Nour. So case 2, 18-year-old male with no significant past medical history presents to the ED with acute onset fatigue, some yellowish discoloration of his skin, sclerae, and some dark urine. Of note, he was diagnosed with a UTI 4 days ago and received 3 days of antibiotics that he doesn't remember the name of. Physical examination is remarkable for jaundice, otherwise normal. CMP is remarkable for, and is there anything underneath that my, because I'm on my iPad, it's kind of crushing the screen. Is it just on the right? Okay, so CMP is remarkable for ALT of 20, AST 50, T-Bili of 6.5, and an ALK FOS of 65. What do you want to do next? So love the Bart Simpson, firstly. So the abnormality would be his T-Bili, significantly elevated to 6.5. ALT is fine, and then the ALK FOS.
It's a little bit elevated.
AST is a bit high, right? I was thinking like that's a tiny bit high. And what do I want to do next? I mean, similarly, I would want to get a CBC. Oh, wait, hold on. I want to check if it's direct or indirect first.
Yeah. So
and let's see, 20 direct. So it's mainly indirect, which is elevated. And I mean, this is, if it's probably second, I mean, just the way the vignette's written, I'm thinking it could be secondary to the antibiotics which was taken. Sounds like he could be like G6PD deficient. And yeah, that's all I can think of right now. Would probably, you can test for that, send that lab test, stop his antibiotics, take it from there.
Yeah, so you're right. I mean, for Gilbert, it's usually won't exceed 3, and this patient has like symptoms, and he has UTI with antibiotics, most likely sulfur related. So he has family history as well. So his hemoglobin was 9.5 with elevated hemolysis labs, including LDH, low haptoglobin, and elevated reticulocyte, bit of a blood smear with white cells and Heinz bodies. We usually do the G6PD after 2 to 3 months from the acute hemolytic episode, because sometimes during the acute episode would be normal, giving the what left from his red blood cells are the normal, are not the ones that had deficiency. So they would be the most recent red blood cells from the bone marrow. So usually it would be normal. So this is just like to let you guys know. Oh, let me go through this. So just like the bilirubin physiology in general, just like think of it as a date. So the single bilirubin, which is like the unconjugated bili, would come from the breakdown of the red blood cells and go to the hepatocyte where it made the matchmaker and converted it to the coupled bilirubin, which is the conjugated, and then the conjugated would go into the biliary tree. And whenever we have like hemolysis, it would be really too much for the cell to handle, and the matchmaker would, hey guys, can you just like give me more time and just go outside, hang out as a single like bilirubin in the blood. And then whenever I had like more time and more space for you, I would find you a mate. And then but like also beside that, sometimes the matchmaker would be not available as like Gilbert disease. It would be like deficiency, sometimes would be totally absent, which is unfortunate for the single guys. And also then, so here's the wedding in the hepatocyte, and then there is the exertion of the couples into their honeymoons. So actually, like the process that would take the most hepatocyte energy is the wedding, which is costly, and then the honeymoon, which is more costly than the wedding. So the first thing that would be dysfunction in the hepatocell whenever you have like chronic liver disease or cirrhosis, the first got injured is the honeymoon because it's the most costly and it's cost the hepatocyte a lot of energy. And then the wedding, and then lastly the uptake. So this is just the date journey. Just like reminder of the causes of indirect hyperbilirubinemia, it might be due to increased bilirubin production because of hemolysis, or we have like a huge hematomas with breakdown of the blood cells. It might be due to impaired uptake into the hepatocytes, which might be due to heart failure, shunts that drag the blood outside the liver, or medication just like rifampin, or it might be impaired conjugation as gallbladder, chronic jar, and hypothyroidism, cirrhosis, and chronic hepatitis. As I mentioned, when there is dysfunction of the hepatocyte, such as chronic hepatitis and cirrhosis, there would be impairment in the first exertion, then conjugation, then the uptake. Third case, who wanna go? Come on, we have a lot of cases.
Who did the first one?
Chris.
Okay, next is Ariana.
I knew it, on God. I saw your eyes on me. No, I'm kidding. I'm happy to read your case, Nour. Okay, so 35-year-old housewife female with no significant past medical history presenting to the clinic as a new patient visit to establish care. On review of symptoms, she reported general mild aches, vital signs and exam were unremarkable. And then her CMP is remarkable for ALT 23, AST 25, Billy 0.3, and alk phos of 250. So her alk phos is elevated to 250. And the rest of her physical exam was normal, right?
Yeah.
I guess I'd like to ask her if she's taking any vitamin supplements or anything else, or any medications.
No.
Nothing
No.
else. Okay. And then Fatma is helping out with a GGT. That sounds
Okay. So here's your GGT. What's next? So it's normal.
Am I still going? Okay. It is normal.
Yeah. So
Yeah. So, okay. Thanks, everyone.
something else. It's not the liver then, right?
Yeah.
So just like want you guys to keep this in mind, that not every elevation in alk phos is liver related. It might be bone.
How old was she?
35.
35.
Okay.
Yeah, the ALP, bone ALP is a good idea. Thanks, Mon.
Yeah. So yeah,
Actually,
it might be from bone. It might be like any condition with high bone turnover might do this. It might be from placenta, or like third trimester of pregnancy. It might be from intestine. It might be from kidneys. So just like to keep this in mind. She's not currently or recently pregnant. She's up to date with cancer screening, giving alk phos might be elevated in some type of malignancies. Calcium found to have low phos, relatively low vitamin D3, and she has like secondary parathyroidism, likely secondary to vitamin D deficiency, which caused elevation in her alk phos. Fourth and last case.
I can go. 31-year-old male presenting to the ED with AMS. On exam was drowsy, difficult to awake, moaning whenever touched, otherwise normal heart, lung, and abdomen exam. Found to have polysubstance intoxications, including cocaine, benzos, and cannabinoids. CMP was remarkable for elevations in ALT, AST greater than ALT, T-belly of 0.4, alk phos of 71.
Okay. What do you want to do next, or what are your thoughts about this labs?
So this looks like a primarily hepatocellular transaminitis with AST much greater than ALT. Did they also test for alcohol as well, along
Yes.
with the UTOX?
Yeah.
Okay. Yeah, so I'd want to get like an alcohol level. I agree with getting hepatitis serologies. A list of medications he's taking, if any. And I guess since we can't really get much of a history from this guy, the AST is can be elevated from a non-hepatic source. So, you know, things like CK and a troponin may help clarify that. I would start with those.
Okay, exactly. So when you ask about alcohol level, you're suspecting alcoholic hepatitis?
Well, I mean, the pattern, I mean, the AST is like, you know, over 4 times ALT, like it's very asymmetric. So, I mean, like just given the asymmetry, I would, you know, alcohol's on the differential. Plus he has other substances in the system, so.
Yeah.
Alcoholic hepatitis usually doesn't go like more than, like up to 300s, 400s, I believe.
Yeah, exactly. So yeah, I mean, this is a good thought that the AST ALT ratio is much more than 2. So like the differential are like limited. And as Ma'an mentioned, that it's really so high for alcoholic hepatitis. So as you mentioned, also given like his cocaine and like substance abuse, we might think about something else. So it seemed like his LDH is very high. He has acute kidney injury. His CK is 70,000, UA positive for myoglobin, and alcohol level was less than 1. Otherwise, they did viral hepatitis panel, which was acute was normal, negative. So this patient most likely have rhabdomyolysis and secondary to his cocaine use. So I just like to keep in mind AST usually found in the liver, muscle, kidney, heart, and brain, and also elevated in hemolysis. ALT more specific to liver disease, but also can be elevated in patient with severe muscle injury, just like this patient. And just a rule that mostly this is a tip for in general, that the AST usually the first one who get like cleared because it has like shorter half-life compared to ALT, and then the ALT and then the ALK-Phas is the last one who get like normal because it has a longer half-life and get like cleared after ALT and AST, just like in general for approaching patient with abnormal liver disease. So this is my first take-home message, that LFT's abnormality might be not related to liver, and you need to broaden your differential and think out of the box before blaming the liver. So this is the end of part 1. Take a breather for like 1 second. And then we'll start with the inpatient hepatology. Just before we start the cases, I just want to give you some tips regarding the type of liver injury. So hepatocellular versus cholestatic, if you open your MedCalc, there is something called R factor, and it's usually calculate the ALT-ALK-Phas ratio. If it's more than 5, it's usually hepatocellular, and we usually have ALT more than 3 times of the upper normal limit. If it's between 2 to 5, it's usually mixed injury, less than 2 cholestatic. And also, guys, just keep in mind that this depends on the timing of presentation. As I mentioned, ALK-Phas is the last to be cleared from the blood. So if the patient is asymptomatic and coming like maybe after 2 weeks from a liver injury, he might only have elevated ALK-Phas, and ALT and ASTs are normal. So just to keep this in mind. Also, when we stratify that severity, we need to keep in mind that there is like acute liver failure with INR more than 1.5 and encephalopathy, and there is severe hepatitis with only INR more than 1.5 without encephalopathy. In regard to the degree of cholestatic injury, might be moderate if ALK-Phas less than 4 upper normal limits and marked if more than 4. Degree of hepatocellular injury, very mild, usually less than 5, mild to moderate, 5 to 1500 upper normal limits and marked elevation. And this doesn't related to the severity of hepatocellular dysfunction because it's only related to coagulopathy and encephalopathy. And we have acute hepatitis less than 6 months, chronic, usually more than 6 months. This is the references for the LFTs, and it's different between male and female, and also age related, and also body mass index, especially for ALT and AST. So just like to keep in mind as well, in any case with suspected liver injury, we need to focus on the history. We need to ask for current and recent medications, herbal supplementation as well, occupational toxic exposure, history of IV drug use, history of high risk sexual activity, history of blood products transfusion, especially before 1990. Personal family history of liver disease or autoimmune disease, comorbidities such as diabetes, hyperlipidemia, obesity for the NAFLD, and alcohol consumption, weight, and BMI. These are so important questions to ask in case of any liver injury. So we have the first case for inpatient hepatology. Who do you want to do it?
Randy is up next.
Sure. So 50-year-old male with a past medical history of AUD, hypertension, poor compliance with medication, presenting with progressively worsening fatigue, anorexia, nausea, and right upper quadrant epigastric pain. On exam, when he was febrile to 38.5 or 101.3 degrees Fahrenheit, lethargic, sclerolicterus, jaundice, hepatomegaly with epigastric and right upper quadrant tenderness. Also found to have sporadic spider angiomas, palmar erythema, shifting dullness. His LFTs were remarkable for AST of 270, ALT of 120, total bili of 13, direct bili of 11.2, alk phos of 240, GGT of 245, albumin of 2.3, INR of 1.5, and a PT of 18.5. Nour, before you change the slide, what does AUD stand for?
Alcoholic use disorder. Sorry.
Sorry, you got it. No problem.
Okay, so what are your thoughts? What do you want to do? So what's like this patient clinically like?
Okay, so this patient, especially with the history of alcohol use, AST greater than ALT and severely elevated, bilirubin, it's kind of a mixed pattern. You could be looking at an alcoholic hepatitis kind of a picture, but also especially with the elevated direct bilirubin and the fever and the lethargy, you could be looking at a cholangitis kind of a picture as well. So I definitely want to get an ultrasound of the right upper quadrant, getting alcohol level 2 to make sure he's not acutely drinking, but he's also showing signs of decompensated cirrhosis as well.
Exactly. So
diagnostic tab. Oh, actually, especially with the decompensated cirrhosis and the fever and altered mental status, you want to rule out SBP, or at least cover for SBP.
Okay, great. So just like some question about the patient information that we discussed about, he only on amlodipine, no herbal supplementation. He doesn't have a job, has remote history of IV drug use, and there is no family history of liver disease or autoimmune disease. Alcohol consumption was consumption more than 20 drinks a week. His BMI is 22. So just before doing further workup, so this patient, his AST ALT ratio is more than 1. So the differential diagnoses include alcoholic hepatitis, cirrhosis, and Wilson disease. Anyone knows why in cirrhosis and Wilson disease AST ALT ratio would be more than 1? Start with cirrhosis. So it's the same mechanism as alcoholic hepatitis. Usually there is dysfunction in the enzyme that usually produce the ALT. So the AST will be more than ALT. As per Wilson disease, any idea?
Just copper, like, because I think if I remember correctly, doesn't like the AST like stored like within mitochondria? Does the copper like disrupt mitochondrial membrane or something like that?
I'm not sure about this, but Wilson disease usually associated with the hemolysis because of the covert toxic effect on the red blood cells. So they usually have hemolysis. That's why also have like AST more than ALT. But in patients with cirrhosis and alcoholic hepatitis, there is dysfunction of the enzyme that usually produce ALT. So the ratio would be different. So these are the only three usual like differential that makes AST more than ALT. Otherwise, less than 1 in daily chronic viral hepatitis, autoimmune hepatitis, NAFLD, genetic disorder, including sometimes Wilson if it doesn't associate with hemolysis, hemochromatosis, and alpha-1 antitrypsin deficiency, malignant infiltration, and congestive hepatopathy. So for the further workup for this patient, he has white counts, mildly hyponatremia. He has, we're not sure if acute or chronic elevation is like kidney injury. UA negative, blood culture were negative because he been febrile, chest X-ray, no pneumonia. For the viral panel, B negative, C positive, but the PCR was negative. So he has like previous Hep C, which most likely resolved by its own. He has otherwise no HIV. For the fluids, for the ascites, he doesn't have spontaneous bacterial peritonitis, and his total bilirubin is 1.6. This is, so when we went to review his chart, this is the first like ultrasound that he got like 2 to 3 years ago. Anyone want to comment on the ultrasound? This one? So we this is the kidney and this is the liver.
It looks like there's, yeah, the liver looks enlarged. There's probably no fluid in Morrison's pouch. I can't tell if the kidney has any, if those are cysts or maybe some hydronephrosis, but it's hard to tell on this view.
Okay, so usually the echogenicity of the kidney and liver would be almost the same, but the liver here looks more like whitish in compared to the, it looks like more hypoechoic compared to the kidney, which is usually abnormal. So that this is one of the signs of steatosis, which we can see in patient with alcoholic use disorder. And usually the edge of the liver will end like here, but here, like here you see that like the liver is overriding the kidney, which one's of the sign of hepatomegaly. And this is his ultrasound now. You can see how the like the edge of the liver is nodular, and he has a lot of like fluids around the liver. And the like the liver seems like coarse and like a little bit nodular, which is like one of the indirect signs of cirrhosis. So when it comes to clinically managing this patient, we really need to know his MELD score, child bug score, MADRI for management of alcoholic hepatitis, and Lilly score after 1 week of like steroids. But like, do you know why like so just like in MELD score, what's the benefit of like a MELD score in such patients?
So MELD score usually tells you like the expected survival rate within 3 months. Correct me if I am wrong.
Yeah, it can help you with the mortality in 30 days and 3 months. And also it's more accurate to see if the patient would benefit from steroid or no, compared to Matter score. Matter score also, if it's like more than 32, it can help you to decide that this patient has poor prognosis and then he might benefit from steroids. How about child score? What's the benefit of calculating child score in general in patient with cirrhosis?
I think like that's one of the scores that is usually used to evaluate for a liver transplant. Yeah,
So
liver transplant.
well, the score is more for liver transplantation. Child score can help with the prognosis, but as well can help you decide, take a decision about treatment.
Okay.
So, for example, if the patient have a small varices, and we want to decide if we want to give him prophylactic treatment, child can help us to do so. If the patient has child C and small varices, we need to give him prophylactic treatment. But if he's child A, there is no need to start beta blockers for him. Also can help for prophylactic for spontaneous bacterial peritonitis if the patient has total bilirubin, total protein in the ascites fluid less than 1.5 and he has child C, then he has higher risk of spontaneous bacterial peritonitis and we need to give him prophylaxis while he's in the hospital. Okay, and Matter score, as I mentioned, help with a decision about steroids, and Lilly score, we can calculate it 7 days after starting the steroids to see if the patient is responsive or no. If no, we just discontinue the steroids. So if yes, we'll continue for 1 month. Okay, so just like general tips about alcoholic hepatitis treatment, level of care, it depends of the patient. Does he have acute liver failure or no? If yes, he needs to be in the ICU, if no, general floors. We need to keep an eye on alcoholic withdrawal symptoms. Hydration, usually we prefer albumin, especially in patient with cirrhosis and underlying kidney injury. Otherwise, if there is no kidney injury, we can do orals for him. For nutrition support, we need to have a good calorie count and protein, in addition to the vitamins, including thiamine and electrolytes repletion. Treatment of cirrhosis complication, including bleeding, spontaneous bacterial peritonitis, encephalopathy, and hepatorenal syndrome. Also, just to keep in mind that such patient has increased risk of infection, and we need to do infection surveillance, especially before starting steroids for them. Also, general tips of treatment. We discussed that if Matter score more than 32 or MELD score more than 20, we can start treatment with glucocorticosteroids. And usually we start prednisolone. Any idea why would we prefer prednisolone over prednisone for such patients?
I think prednisone needs to be converted to prednisolone act, and that's done in the liver. So if someone's liver is affected, you want to give them the act.
Great. Okay, so we'll do that. Usually 40 milligram for 28 days, unless the patient is not responding. And there is also contraindication, including active bacterial fungal infection or chronic hepatitis B or C. We need to monitor for gastrointestinal bleeding, glucose intolerance, and such patient usually need also prophylaxis with PBI or famotidine. Both of treatment, actually, they have inconclusive evidence of efficacy. Pentoxifylline as well is controversial, but usually we give it for patients who have contraindication for glucocorticosteroids. And they are more beneficial in patient with usually patient with renal failure compared to glucocorticosteroids. Okay. Actually, I'm gonna skip those.
Just one thing I would add. So if there's a patient with severe alcoholic hepatitis, that is not a contraindication for liver transplant. So liver transplant in patients with severe acute alcoholic hepatitis who do not respond to medical therapy, early liver transplantation improves survival. So that's one important thing we have to keep in mind, because sometimes we think, oh, this patient's taking alcohol, not a candidate. That's not true, and more and more data is coming that patients with the first episode of severe alc-hep doing liver transplant early is actually one of the most important things, because there's a 30% survival rate for these patients. So I'll put some studies in the chat, but just remember, don't rule out liver transplant for patients, even if they have alcohol.
Though like 6 months ago, I was in Florida and I had a patient with cirrhosis, like alcoholic related cirrhosis with, on top of that, had alcoholic hepatitis, and he had like acute liver failure. We reached out to Mount Sinai Hospital and they just like refused the case because he's actively drinking. So I'm not sure. I mean, you're totally right.
So if it's the first episode of severe alcohol, if it's multiple, then
yeah, his first episode, but he has like alcoholic use disorder. He has like cirrhosis, which and active drinking. Maybe it's like case by case, but the patient was like really clinically ill, and maybe he wouldn't be able to tolerate liver transplantation anyway. But he ended up dying the next day. And for
Nour, I think it is just as you said, it's case by case, because I had a patient who had alcoholic hepatitis and we reached out to Sinai and she went and she got the transplant. So I think if the patient have a good support, social support and other factors in place, I think they will go. So anyway, anyone with acute liver failure, we have to reach out to them. Especially if alcoholic hepatitis, as Angat said.
Yeah, totally. Okay. So start the next case. Anyone?
Kirtana, you're up.
Can I come back in 2 minutes? I just got an epic chat from my interns about a flow patient.
Sure. Matt?
The 55-year-old female, past medical history, diabetes, hypertension, fibromyalgia, presenting with acute onset right upper quadrant abdominal pain, along with nausea, vomiting, fever, and dark urine. Exam is remarkable for fever, tachycardia, jaundice, right upper quadrant ultrasound. Her LFTs are remarkable for AST elevated to 1,000, ALT to 1,200, T-Billy of 7, D-Billy 6.2, ALK 455, GGT 245, albumin 4.2, and an INR of 1.3. So the worry here seems like it would probably be for some sort of acute infection like cholangitis. So I would definitely get an abdominal ultrasound first.
Great. So just like when you see elevation to this point in the ALT-AST, would that be explained by this presentation? Or your thoughts?
I mean, it could be. I think that if you're worried about something very acute, then perhaps it could be explained with enzymes so significantly elevated.
Okay. And so this patient, info, he's on amlodipine 10, metformin 1 BID, Tylenol, duloxetine, no recent herbal, housewife, no history of IV drug use or high-risk sexual activity, history of gallstone in the mother, no personal family history, autoimmune diseases, alcohol 5 drinks a week, and her BMI is 34.8. In regard to the rest of the labs, she has a Y count. She has lactate of 4.3. Her lipase is 140. Viral panel was mostly negative. Acetaminophen level was negative, blood culture negative, and chest X-ray negative. Here's the ultrasound. Anyone want to comment on this?
I see there is an enlarged gallbladder. I believe the wall looks thickened, and I can see at the base of the gallbladder, like you can see on the cross section on the long axis, like it's a very irregular border. Like I think those are the gallstones, and it's causing the acoustic shadow. There may be multiple, yeah.
Yeah.
And then I trying to see if I can see like a dilated common bile duct, but I cannot identify that yet.
So usually you need a different view. I don't think you can see the gallbladder and the common bile duct in the same one. So as you mentioned, this is the gallbladder. Actually, there is no thickening or like fluids around it, but there is a lot of like stones. And this is the acoustic shadow. And this is the also another transfer view. This is the common bile duct. It's dilated and there is a stone here. Usually we don't see it, but some cases we can. And here's the MRCB with a stone here and the common bile duct dilated here. Okay, so just differential diagnosis for marked Transtaminitis. Usually we see it in acute viral hepatitis, toxin-related, especially acetaminophen, ischemic hepatitis, and acute biliary obstruction. It's not related to hepatocyte injury, but it's really like just for the acute sudden, like a stunned liver due to the obstruction. We can differentiate that. Like you can really, if there is the obstruction is resolved, you can have normal like LFTs in few days, like up to 2 to 5 days, which is much faster than the ischemic, and then the like viral hepatitis usually would take weeks. And less common causes would be acute exacerbation of chronic Hep B, autoimmune hepatitis, Wilson, and Budd-Chiari. Usually gallstone complication, biliary colic, cholecystitis, cholelithiasis, acute pancreatitis, cholangitis, and secondary biliary cirrhosis. If we have structural obstruction for more than 6 months, we might have secondary actually biliary cirrhosis, which is relatively very fast cirrhosis compared to other etiology. So just like tips about the probability of having cholelithiasis. Usually patient would have high probability, more than 50, if we see a stone inside the common bile duct, or there is acute cholangitis or total bilirubin more than 4 with evidence of dilation of the common bile duct, even if we didn't see the stone inside. The intermediate risk is like probability of having a stone. 10 to 50% if there is abnormal liver test, age more than 55, and dilated common bile duct, and low risk less than 10% probability there is no predictor like presents, but like I'm gonna focus on that because this would change the management. If we have a high risk patient, we usually go immediately into ERCP to remove the stone. If we have intermediate risk, we usually go into either MRCP or EOS to see if there is stone inside. If there is, we're gonna refer the patient to do ERCP. If there is not, just to surgery to remove his gallbladder. If it's low risk, we don't know. We don't usually explore the common bile duct. It's just like the patient referred to surgery to do the cholecystectomy. And we usually it's really if the stone stuck in the like a common bile duct for a while, it might cause cholangitis, which usually diagnosed with Charcot's fever, abdominal pain, and jaundice. Usually we would have an inflammatory response, white count, C-reactive protein, and we usually divide the severity. It's usually severe if there is any end organ damage like respiratory dysfunction, septic shock, acute kidney injury, usually moderate if there is no end organ damage, but there is like high risk patient, including age more than 75, white count more than 12, bilirubin more than 5, and low albumin. Mild cholangitis usually doesn't meet any of the previous criteria. And our management would be supportive care, antibiotics, and biliary drainage. Biliary drainage is the most important one. It's like the infection source control. Antibiotics, it depends on the patient comorbidities, previous cultures, if it's community acquired versus hospital acquired. All the time we need to cover for gram-negative and anaerobics. So as I mentioned, it's just based on comorbidities, community versus hospital acquired, and previous drug-resistant bugs. Third case, and mostly the last case.
I can do this one since I went AWOL for the last one. 58-year-old male with past medical history of hypertension, presenting with fatigue, weight loss, increased abdominal girth, and constipation. Exam was remarkable for cachexia, jaundice, hepatomegaly, and positive shifting dullness. His LFTs are remarkable for AST, ALT elevated to the hundreds. ALT is more than AST. Elevated total bilirubin, which is mostly direct. He has an elevated ALK, FOS, and GGT. Albumin is 3.1, INR is 1.7. So I guess we start with the questions that we asked: medication, supplements, alcohol, job. Okay, amlodipine, no supplements. Doorman. Is AID autoimmune diseases? No?
Yes.
Okay. He consumes alcohol. BMI is 22. So just from his history, it seems like he has like some features of chronic liver disease. And positive shifting dullness, so probably has ascites as well. So probably start with an ultrasound of the abdomen to see if there's ascites.
So
yes,
from his clinical exam, there wasn't like signs of stigmata of chronic liver disease.
Okay.
There is like no known personal liver history. And it just like all started in the past 6 months with this like weight loss, poor appetite, gradually worsening jaundice, and like increased abdomen girth. So
okay.
when you see his labs, well, what's like, is it like hepatocellular or
I mean, the alphas is like out of proportion, I guess, for the transaminitis.
So it's mostly cholestatic, right?
Yeah.
Okay. So when we have a cholestatic injury, we usually like differentiate between intrahepatic and extrahepatic cholestatic liver injury. And as you mentioned, it's like the main thing that can help us differentiate is ultrasound or imaging in general. But just like to think of it, what would your differential, if it's like intra versus extra hepatic cholestatic, like what you need to keep in mind?
I guess, I mean, if we were talking about like structural diseases, it could be like liver, or it could be biliary tract. So if there was like a cholangiocarcinoma or a tumor in the biliary tract versus if it's a hepatocellular carcinoma or like a Klatskin tumor or something, I guess, or even like non-neoplastic causes of obstruction. I'm not sure how else to differentiate based on these labs.
It would be easier if we get the ultrasound and then we maybe have a list of extra versus intrahepatic cholestasis. So, sorry. So his actually ultrasound didn't report any dilatation, and this is his there is no intra or extrahepatic dilatation. His common bile duct was normal, gallbladder was normal, and this is the rest of his labs. He had microstatic anemia, acute kidney injury, has elevated LDH, ascites fluid with white count 700, but 80% lymphocytes. I just need 2 minutes.
Okay, we have this room, so
Okay, sorry.
quickly.
Okay, almost done. So this, like otherwise the studies were negative. This is the ultrasound. Seeing like he has a lot of like masses in his liver, and he ended up having colonoscopy with colon cancer. So just like for the differential, for extrahepatic cholestasis, we usually have problem in the biliary tree, either choledocholitis stones or like tumor somewhere here, and infection in the biliary tree, including Ascaris, liver flukes, and HIV-related cholangiopathy, or if there is like intrahepatic cholestasis, usually either the hepatocell is like damaged in cirrhosis, chronic hepatitis, or there is dysfunction in the exertion of the bilirubin, or if there is like some infiltration here, either water from heart failure or malignancy, like, or amyloids. So just like to keep in mind, this is like the skyrocket elevation in the ALK-FAS is usually infiltrative disease rather than biliary tree disease. Just like to keep this in mind, especially for metastases, high burden cholangiocarcinoma, or primary liver malignancies, or amyloids, or lymphoma, and such like a very high ALK-FAS. So this is my last case. Any questions?
Nour, that was really good. Thank you so much. I have a question I forgot to ask earlier. For alcoholic hepatitis, if they have an active infection, so you decide to not give steroids, can you wait for the infection to be treated and then give the steroids, or how long is the window?
Yeah, so you need to treat the infection, especially if it's like severe, like with bacteremia, because even like steroids rule in alcoholic hepatitis is controversial and inconsistent evidence of efficacy. So we don't want to like to drug the patient to the ICU because of the sepsis. So just like treat the infection, and then if the patient is stable and steady, his sepsis is controlled, then you can start local corticosteroids and consulting liver service and Mount Sinai Hospital, just to give them, even if the patient, especially if the patient has like elevated INR or encephalopathy, like acute liver failure. So
perfect. Thanks so much.
Thank you so much, Nour. Let's wrap it up there. We are actually running short on time, and we'll be back in 2 minutes.
okay.